Dr. Fitzgerald is the creator of the New Mexico, quote unquote, 5 Actions program, which is trademarked for addiction. He has been on clinical faculty in the Department of Psychiatry at Oregon Health and Sciences University since 1998, a licensed professional counselor in Oregon since 2001, and a certified addiction specialist since 2006. He holds a doctoral degree in systems science and social psychology from the Systems Science Graduate Program at Portland State University, where he has also held an adjunct faculty position since 2007. Welcome, Dr. Fitzgerald, or as John, as you would like us to refer to you as. Really appreciate, we'll call you John, that works fine with me. And really appreciate you speaking us tonight, and take it away. We're gonna have John speak for a half hour, 40 minutes. If you have some compelling question or something that wasn't very clear that John's covering, feel free to ask it in the chat or raise your virtual hand, and John will get to it. Otherwise, we're going to do Q&A for the most part after John's presentation. Thanks again, John, and take it away.
Thanks, Craig. Yeah, so welcome everybody. We were just talking before everybody joined about how you have a little bit of snow. It's a little bit cold there right now. I'm in Oregon, so we have kind of cold and rain here, but not quite the same temperatures that you guys have. So it's great to be with all of you. I'm going to go ahead and talk for maybe about 30, 40 minutes. I've got a slide deck. I'll make the deck available so that you guys, you don't have to take notes. You'll make sure that you get a copy of it. I'm going to reference a bunch of books as I do in these webinars. So let me pull up my slides and let's see here. Here. All right. And somebody give me the heads up. You guys can see this okay? Yes?
Yes.
Yes, it looks good.
Perfect. Thank you. Okay. All right. So yeah, feel free. We can keep this fairly informal. If you guys have a question, I can't really see you right now with the slides, but feel free to, if there's something that comes up, you can blurt it out or whatever. We can handle it. Otherwise, you can write it down and we'll handle it at the end of the talk. This is kind of a new topic for me. I have to say it's kind of biting off a lot here, kind of connecting the dots between serious mental illness and this idea of continuous traumatic stress. Talk a little bit more about my interest in that topic, and then linking all of that to, what does that mean for optimizing care for both patients as well as family members. What I'm going to do is I'll do a brief introduction, give you a little bit of my background, as well as a little bit more personal background on how that relates to continuous traumatic stress. And then we'll talk a little bit about the nature of CTS and how it relates to serious mental illness, and finish up with optimizing care. So just a little bit of background and disclosures. Craig already mentioned a little bit about my background. You can kind of see the education on the left. I practice as a licensed professional counselor since 2001, certified addiction specialist. I'm on faculty at Oregon Health and Sciences University in Portland State. Currently, my 3 work streams are that I have a private practice. When COVID hit, I went teletherapy. It's pretty small right now, maybe 4 or 5 hours a week. I also have a company that I started in 2018, Digital Therapeutics Group, that really evolved out of my work with digital therapeutics specific to addiction. So some of you may know of that work. I'll talk a little bit more about that in a minute. But we launched a program in New Mexico as well as in Alaska. And then lastly, I also I'm a medical science liaison for the biopharmaceutical company Alkermes. Alkermes makes behavioral health medicines. I just want to make a note that this presentation has nothing to do with my Alkermes work, but I just wanted to disclose that. So for those of you who are familiar with this program, I apologize. I want to just run through this very quickly, but in November of 2020, we launched the New Mexico 5 Actions program, which is a self-guided roadmap to understanding and addressing addiction, both substance as well as behavioral. It's a mobile-friendly platform. It's free for everyone who signs up to use the program. There's over 125 videos. There's screening tools, as well as links to access treatment, as well as a variety of other resources. And what's unique is that we've paired it up with the New Mexico Crisis and Access Line so that they've also been trained. And so you can not only use this as kind of a digital health tool, but you also have access then, of course, to the warm line and the crisis call takers. So I am really, really impressed with New Mexico and everything that they've been doing in terms of bringing in lots of innovative, unique programs. I wish Oregon would do the same. But if you haven't signed up for it or you're not aware about this program, I encourage you to check it out. We also do live webinars, and so you might have attended a live webinar. I've been doing those for a couple years, and I've brought in some different guests. We don't have a lineup yet for 2024, but that will be coming out shortly, and that's 5actionswebinars.com, and we've got all our past webinars on there as well. So I want to just give you a little personal history before I jump into talking about kind of this topic. And the personal history is sort of my relationship to continuous traumatic stress. When my wife and I, we had a son, and during the first few months, it was clear that something was wrong and that he wasn't growing. And we ended up by going into the hospital, and he came out with a nasogastric feeding tube, the tube that goes into your nose, down into your stomach. And we were going to have that for about 6 to 8 weeks. And it turned out that we ended up by feeding him that way for about 1.5 years. And at nighttime, we would hook him up to a machine. And as the calories went into his body, he would often trajectory vomit all over the place. So needless to say, this was sort of my introduction to really kind of continuous stress. I'll talk a little bit more about what makes it traumatic, but what ended up by happening, he got to the age of 2, still wasn't growing. So we put him on growth hormone shots. And after 3 months, went into the doctor, and he had not grown. He actually had lost weight. And as you might imagine, as a parent, my wife and I, we got very worried, a lot of fear. We didn't know what to do next. We had no diagnosis. The systems of care that we had accessed were very fragmented, things very, very similar to behavioral health. But I had learned about a growth conference in Chicago around this same time. So I hopped on a plane, I flew to Chicago. I had his medical chart with me, and I got off of a night flight, and a very nice woman probably looked at me and thought I'm kind of pretty distressed and distraught. And she came up to me and asked why I was there. And I said, I don't really know, but I think my kid has a growth disorder. And she quickly looked at the medical chart. She said, follow me. We went into a kind of a little one of the rooms down the hall, and it was dark, and she threw the chart on a table, and this doctor sat there, looked at it, and just looked up after about 30 seconds and said, your kid has this diagnosis, just like that. And I thought, how do you know? And she said, well, this is what I do. Come to my talks. And the long story short is that we did visit her. She actually worked out of New York City, and he did have the diagnosis. It was a specific growth disorder. And what the treatment really entailed was visiting with her or seeing her every 3 months for about 15 years. And in some ways during that time period, getting on flights every 3 months. And I recognized that we were in somewhat of a very privileged position to be able to do it, but we also completely retooled our life to make these trips possible with our jobs. We all of our vacations, of course, became retooled to happen in New York City, and that became our life. And during that time period, there were many stressful, almost traumatic, stressful things that were very overwhelming during that time period, where he wouldn't get on the flights, he didn't want to have blood work done, all kinds of things. But that really is partly my own sort of journey into this topic of continuous traumatic stress that I'm going to come to in just a minute. What I want to kind of return to is a talk you guys had, I think a couple months ago by Dr. Thomas Insel that I thought was fantastic. I went back and I was listening to his talk, also the talk by Ken Duckworth. And on the left is sort of what I took away summarizing. He just was so brilliant at saying, look, we don't just have one behavioral health crisis. We have a youth mental health crisis. We have serious mental illness, and we have addiction. We have the deaths of despair. And then I thought he did a really wonderful job of sort of mapping out all of the different challenges related to the systems of care. So I'm not going to repeat any of that, but I just want to acknowledge that I think he did a wonderful job, and he's kind of set the stage for the fact that, yes, people who are suffering and struggling right now with, mental illness and addiction are finding themselves in a very challenged time. One of the things that I would add to that is these reports that come out from the American Psychological Association called Stress in America. I've been tracking these for a number of years. I've used them in some of my webinars. This is the latest APA 2023. And if you look down here at the bottom left, I'm just highlighting a couple of these. And again, I'll give you guys these slides. But 47% of 18 to 34-year-olds say on most days they are so stressed they can't function. 39% of the 35 to 44-year-olds. You can look across the board, and it seems like a protective factor is actually being a bit older, more resilient. If you look over here on the right, most days their stress is completely overwhelming. 58% of people in the 18 to 34-year-old group, 46% in the 35 to 44. So within this backdrop of this incredibly challenged mental health and addiction treatment system, we have, I think, incredible levels of stress that we are seeing at rates that we just haven't seen in the past. And I think some of this is, of course, kind of post-COVID catching up. When we look at parents, again, there's a lot of charts on here, but again, some similar numbers over here on the bottom left. Parents were significantly more likely than other adults to say most days their stress is completely overwhelming, 48%. And over here on the right, when they are stressed, they can't bring themselves to do anything, 50%. And for parents, most days they're so stressed they can't function, 41%. So when we think about people who are already suffering with, again, mental health, addictions, or caregivers that are parents trying to care for their loved ones, and we put this stress as the backdrop, we really complicate the situation in ways because, again, we're starting to see just these high rates of stress. Now, this sort of leads me into this idea of continuous traumatic stress. During the pandemic, I was looking at different models of trying to understand what I was feeling and what I was going through. And I came upon the work of a couple clinicians that were working in South Africa during apartheid Africa. And what was happening was patients were coming in that had been sexually, physically abused, some incredibly horrible traumas. The clinicians were working with them, but they realized that this wasn't PTSD because this wasn't in the past. It was actually occurring in present time. And in addition to treating them, they were sending them back out into an environment where the traumas would continue. So they developed this framework of continuous traumatic stress. And there's a number of pieces of it that I think really resonated with me, particularly around the pandemic, but also when I thought about sort of my own kind of medical challenges with my son. One was I liked the fact that they put it into a non-pathologizing language. It was a recognition that anybody going through such stressors would have similar symptoms. And that what really separated it from just everyday chronic stress was that there was a life-threatening element to it, that if somebody wasn't getting treatment, we can think about, again, within SMI, the idea of overdose deaths with drugs or with suicide. There's real life-threatening stress that is playing out. Also a future focus. So the idea that in addition to potentially trauma that's happened in the past, that there's this idea that I think more is to come. And in fact, I've got this sort of perspective now that I know more is going to come. So my nervous system starts becoming hypervigilant. There's also threats that are largely faceless. This really kind of made sense around the pandemic. We don't see little COVIDs floating around. But the idea also is I think a lot of mental illness addiction is faceless. People, again, there's a stigma around this. And it plays out in unpredictable ways. So anybody who is trying to manage people who have serious mental illness know that it's a bit of a roller coaster. At times, it's pretty calm and medicines and interventions work really well. And at other times, it's very unpredictable. Also, this preoccupation with future safety. So getting back to, again, the fact that I don't know what's coming, but I need to be hypervigilant to the fact that I know what I've been through already. So I need to sort of prepare for the future, and I have a preoccupation on the future. And lastly, the absence of protections. In this case, they were talking about, again, absence of protections from a breakdown in community, law and order, a predictable functioning society. Some of this stuff applies a bit more to what we saw in the pandemic. But clearly, when you think about all of the variables that Thomas Insel covered, and we think about our current treatment system, one could argue that there is a lack of protections. And in fact, I think he made the point that the biggest cost is not treating people who are really suffering and struggling. So there was a lot about this continuous traumatic stress that just really resonated with me and helped me to, in some ways, feel like I wasn't going crazy, that in some ways it was ongoing. And what made it traumatic, when we think about what differentiates stress from traumatic stress, in general, the way I like to think about trauma is that it's an event that overwhelms our developmental capacities to really address it. Trauma is not defined by the event, but it's really defined by the way that somebody responds to that event. So again, there could be a traumatic event, and yet, again, people can respond to it in different ways, which ultimately then leads to different traumatic responses. But in many ways, it's traumatic when, in some ways, those symptoms, that stress is at a level that I just don't have the capacities to manage in a good way. I want to drop in a little bit deeper on this sort of topic on trauma. I really like the work of Dr. Joe Ledoux. He runs a lab in New York. He's wrote a number of books you may be familiar with. This is a model that came out of the emotional brain. And part of what he maps out in this book are these high and low roads to fear that really map onto trauma. And so what happens is that when there is a traumatic event or an exposure, it comes in through our various senses. And that sort of mix of sensory input gets processed by the thalamus. In Bessel van der Kolk's best-selling book, The Body Keeps the Score, he calls the thalamus the cook. And it processes it and it sends the information to two different places. The high road is it goes up to the prefrontal cortex that, again, he calls the watchtower, where it gets processed. It's more accurate, but it's a little slow. The low road, the quick and dirty route, which is what Joe Ledoux mapped out, is to the amygdala, the emotional part of the brain, or what Bessel would call the smoke detector. And that leads to this emotional response. So imagine that you're walking through the woods, you step on something, you hear this crack, and you immediately have sort of emotion that rushes in, you jump back. That would be, again, the low road. It's quick and dirty, but you quickly react. And then you look down, and with your prefrontal cortex, you process, oh, that was a stick. That was not a snake. And then you walk on. So the idea is we have these two roads because in a trauma, if we had to take the time to process it, we might be dead. So that's why, in evolutionary kind of terms, we've developed this low road. So what happens is people have been exposed to traumas and stressors is that the thalamus becomes oversensitive and the prefrontal cortex loses its sort of ability to process. The amygdala becomes overactive, and what gets attuned in the nervous system is this fight, flight, freeze response. I'll talk a little bit more about that. And in some ways, I think what happens with continuous traumatic stress is that as people are continuing to have situations that are overwhelming hit them, their body again starts attuning to that in this way, and it becomes much more attuned to being habituated in this sort of fight, flight, freeze. When we think about how to interact on this, and so I want to do kind of a bit preview, there's really sort of these two ways of intervening. The top-down regulation, when we talk about treatments and interventions, is that we want to strengthen people's ability to pay attention in the present moment, to body sensations, to process what's going on, to think more clearly. We strengthen that prefrontal cortex and top-down regulation. The bottom-up regulation really involves working with the body. This is somatic, and it involves recalibrating the autonomic nervous system. So for people who have really, again, gone down a path where there's a lot of stress, and some of that stress becomes traumatic stress, working with the body to relieve that and relieve the nervous system becomes really, really important. Some of the work that's been done in that area comes from Stephen Porges. He developed polyvagal theory. I won't go into a lot of detail, but it's essentially kind of the biology of safety and danger. And on the left here, you can see that the polyvagal nerve sort of runs kind of from the head all the way down into the gut. And what he really mapped out in polyvagal theory was the idea that when somebody has a trauma, the first line of defense is to have the social engagement where we become calm and we get self-soothing. We have somebody that helps regulate us. And sort of this is the ventral vagal response. But in a trauma or in a stress, if there's really nobody there to help us or calm us down, and we are sort of in the midst of it, the first sort of response is we get a bunch of adrenaline that flows into the system. This is sort of in the chest. And there's this fight or flight response that I think most of us are aware of. And if that doesn't work, then the brain and body, if they're interpreting a situation, which is, I can't get out of this, I can't fight my way and I can't really run, then there's a deeper, what he calls a dorsal vagal response in the gut, where the natural opioids flood the body and people shut down, they freeze, they collapse. So again, if we think about this continuous traumatic stress and people going down a pathway where a variety of things hit, polyvagal theory really helps to see how that stress can get mapped out into the nervous system in different ways. And in some ways, what I've talked about in other topics, we don't really have time today, is that this nervous system then maps onto a variety of different addictions. And you can think about sort of uppers, downers, all arounders, but people who have a fight flight often kind of attuned to stimulants, and those that move into the immobilization freeze response, we often see drinking more alcohol and opioids. So I want to kind of move from that individual sort of response to the work of George Bonanno. He also, I think, works in New York and really has studied the variety of ways that people respond to stress and trauma. And a lot of his work kind of led to this graphic on the right, where he sort of mapped out trajectories over time. And he really sort of has shown that there are 4 different ways that we respond to stress and trauma after what he would call kind of a traumatic event. And one, he would say, is the path of resilience, where he says, you know, most people, no matter what you throw at them, are pretty resilient, 35 to 65% of people. You know, it can be a stress, it can be a trauma, they bounce back pretty quickly. The second path of recovery is this idea that, you know, after a traumatic experience or stress, they have a heightened level of symptoms, but then eventually they drop off, kind of people recover. The third is that people have a big stress or a trauma, but they don't have as much symptoms. They show less clinical symptoms, but over time, actually, they struggle more and more in the aftermath. There's this delayed response, 0 to 15%. And then the final pathway are people who, prior to a lot of stress or trauma, they have underlying already chronic medical or behavioral health conditions. So as you might anticipate or expect, people who are already in that bucket, if you give them more trauma and stress, they kind of stay in this chronic space. And so these become these sort of different trajectories that play out over time. He wrote a book called The End of Trauma. In that book, he said, teaching people how they might become more resilient has always seemed to me to be out of reach. Resilience is complicated and, as we've seen, hard to predict with any accuracy. We can put a lot of effort into cultivating whatever resilience-promoting traits appear on whatever list we might come across, only to discover that we've barely moved the needle. Flexibility, on the other hand, gives us something to work with. And there's a wonderful book that I also recommend called The Power of Discord that really says the same thing, that resilience comes from all of the different interactions of having a stress or trauma and then actually kind of recovering from it. And so it's that sort of break recovery over time that builds resilience. It's not, you know, something that we all of a sudden at the end of this trauma we can kind of pull out of a hat. I did ask him. He and I had some conversations, and one of the things that he came back and said to me was that really the best that we can do is continue to monitor symptoms and do the best we can in the moment. So what about this sort of flexibility? So in the book, he maps out kind of two ideas, a flexibility mindset and a flexibility sequence. The mindset is this idea that we need to kind of think about having optimism, that the future is going to be okay, and that we have confidence that I've got these coping skills that I can manage, and that no matter what the challenge that's thrown at me, I can come up with interventions and options to figure out what's necessary to get it done. So there's these different components that he talks more about in the book, but that our mindset stays flexible. But it's basically the idea that as we're going forward in life, yes, we're on a roller coaster and I don't know what's coming, but that doesn't mean that I can't be optimistic and I can't sort of, again, maintain this flexible mindset. And with it, he then maps out what he calls the flexibility sequence, which is, well, okay, what do we do then in these situations? And he really talks about three things: the content sensitivity, which is, well, what is happening? What do I need to do? The second is, what am I able to do? The repertoire of interventions. And then lastly, is it working? So I want to take just a little bit deeper dive into these three, back to kind of what we've been talking about with serious mental illness, continuous traumatic stress. And so we start with, well, what is happening? This kind of first step. And on the left is a graphic that I like to use, partly because it sort of illustrates this idea that we come into the world with a baseline set of biology, genetics, but it really doesn't dictate our life. We know that the biology and genetics can play a role, but that really it's interaction with the environment over time that leads to the different trajectories in our lives. And the very first thing that happens when we come into this world is really those first 2 to 3 years of attachment. This is a big topic that if there's more questions in the Q&A, we can address it. But John Bowlby, the father of attachment theory, said that attachment, which is the relational template one has cradle to grave, is really in place around the ages of 2 to 3 years old. So again, if you think about it, this is preconscious and it's like genetics. You inherit a relational template from your caregivers or parents that's in place at 2 years of age. In the United States, about 40% of people have a version that we would call insecure attachment, that leads to less flexibility and less really healthy relationships, much more challenging. 60% of people have a secure base of attachment, which means they can go out in the world and do much better in relationships. But based on this foundation of attachment, we then have all kinds of adverse childhood experiences. We see co-occurring mental health issues. We see trajectories with addiction. But ultimately, what emerges in the 20s, 30s, and sometimes it can happen earlier or later, is that we see this emergence of serious mental illness. So early on, I think what's necessary is that we need powerful screening tools, ways of assessing the constellation of symptoms that people are struggling with. I really appreciated in the Q&A of Dr. Insel's talk that somebody had asked, or at least commented, that we often do some pretty good screening, particularly in primary care, but there's often not a lot of follow-up because we have a challenged system. And I thought that's absolutely true. I really believe that what we need is a collection of really validated assessment tools, screening tools that people can access 24/7 that allow them to not only see specific symptoms, but how those symptoms interact with each other. And having those symptoms and those screening tools then output to the next piece of this, which would then be, what do I need to do? And really what comes after screening and assessment, and I'm not really talking diagnosis here. I think that we can do a lot of good in helping people just navigate what the symptoms that they have are. And in the learning part of this, have really powerful educational tools. I think NAMI has a ton of really great educational tools. I think that we are on the verge of being able to use digital health products to fill this gap. But education is really, really important. And in some ways, I think there are clinicians I know that would argue that education is a type of intervention. I just want to comment on a couple things related to education. I just want to sort of fit a couple things in here. this is the fact that there are some new emerging treatments coming down the pike for schizophrenia. Some of you may already be aware of this, but if you're not, I just wanted to put a couple markers in there. There's a journal article. You can Google this. It's you can come up with the PDF on this, new developments in the treatment of schizophrenia. But for a number of decades, we have had sort of a collection of medicines that have worked okay. They, in some ways, have a variety of downstream side effects that are well known to people that are on these sort of antipsychotics and atypical second generation antipsychotics. What's emerging is a whole new class of medicines, what we're calling TAR1 agonists and these muscarinic receptor agonists. Some of these newer investigational agents like KarXT, ulotaront, they're actually, in some ways, already filing for NDAs with the FDA. These are new mechanism of actions. These are some really exciting medications that for people who are struggling, I think can provide some really significant hope, not in 5 to 10 years, but actually in the next, 1, 2, 3 years. So for anybody that is interested in some of these emerging treatments for schizophrenia, I really encourage you to take a look at this paper. And there's other talks out there about some of these new emerging medicines. Also in the area of depression and bipolarity, I have a colleague that has ran this website, Psych Education. This is just an example, I think, of what I believe to be really good, solid education in helping people learn about symptoms. So a good example is that you can go into primary care, or you could do a screening tool like the PHQ-9 for depression. And out of that, you can say, well, it looks like I've got some depression here. But really, the learning that occurs after that is, well, what type of depression do I have? And many people just assume that depression's depression. And that's not the case, as most of you know, that it falls on a spectrum. Unipolar depression is treated very, very different than when we move on to the spectrum and we start talking about bipolarity. So part of what learning can do is help people to screen for, say, something at a high level like depression, and then through the educational tools, help people to take a deeper dive on, well, what types of depression are there, and what are the different trajectories, and what fits for me? And then that leads into, of course, what are the various types of treatments and interventions to address these different issues. So that leads to kind of this third bucket of the interventions. So we have the assessment and screening, we have the educational, the learning, and then we have, okay, now what do I do about it? In the address part, I really have sort of two buckets. One is that they're self-guided interventions that people can do on their own. And I think because of the challenges of accessing treatment today, we need to understand what are the very best evidence-based practices that people can engage on their own for a variety of different conditions. That's something that I've been really working hard at to bring into the NM5 Actions program, as well as other types of products that I've been working on in a broader way. But the other bucket is that we do know that some of these interventions, you need to access clinicians to get medicines. And as in the past videos that I watched with Ken Duckworth and Thomas Insel, that can be really hard to do. So I want to give you, kind of finish up this talk, and then we'll open it up to questions, is just kind of 3 key levers that I see to optimize outcomes, really for patients and clinicians, or patients and family members, rather. And the first is, there's no way we're going to meet the needs with face-to-face clinicians. We have such a huge gap that I believe the hope really is that we can use digital health and digital types of medicines and interventions. Part of why I show this is, if we look at these graphs around smartphone penetration starting in 2005 to 2016, I know these are a little dated, but part of what this illustrates, as well as looking at the same kind of graph for broadband, is the ability to use technology is a rather new innovation. Really, truly, only in the last 5 to 10 years have we been in a position where we can start taking advantage of these technologies. So in my experience in this field, we're just scratching the surface. And to me, that's exciting, because there's a lot of ways that we might incorporate AI, as well as a lot of newer technologies and treatments that can come by way of using these digital ways of getting this out to people. it's a very exciting time to be in this space. But as people know that have been here, there's lots of things coming and going. Just a couple of years ago, a company, Pear Therapeutics, had a valuation of 1.5 billion, and now they're out of business. So all of that to say that I think technology will help us close the gap. I don't think it's going to replace clinicians. We're going to need face-to-face clinicians, but we're going to have a new treatment system going forward that has to integrate technology into it. My second key lever is a focus on emotion. I love Stanley Greenspan's work. He passed a number of years ago. He's wrote a number of books. This is one of the ones that I really love. And in this book, he says, an understanding of the role of emotions at the root of all mental development helps us define the elusive concept of mental health. If mental health is defined by a person's mastery of a series of developmental tasks, the acquisition of the capacity to reflect, to relate deeply to others, and to regard others with empathy in the face of stress or change, we will insist on the importance of intimate interpersonal experiences and emotional growth. So for me, at the heart of helping people, when I often do consults with patients or families, what I often end up by moving into is this space of talking about emotion. One of the best interventions that has emerged over the last, I don't know, 3, 4, 5 years comes out of the work of David Barlow in Boston. And it's known as the Unified Protocol for Transdiagnostic Emotional Disorders. They have wonderful workbooks you can buy off of Amazon, but what they really focused on is the idea that at the core of a lot of emotional problems is dysregulated emotion. So they've developed one protocol to help people become embodied, to learn to regulate this dysregulated emotion. And when it comes back to how do we work with stress, continuous traumatic stress, in many ways, it comes back to the body somatically, the bottom-up approach. And then my final key lever is just that I believe that we over-pathologize a lot of what we do. I heard Thomas Insel say that, we need to look beyond symptoms. I couldn't agree more. People and people who struggle are more than their symptoms. But we spend so much time thinking about how to get symptoms to go away that we miss this other framework that is really about this idea of creating. It's the idea that we set aside all the symptoms and we say, what is it that I want to help this person bring into their life? Robert Fritz has wrote a number of books, and he says in the book Creating that creating is not designed to heal you, fix you, or satisfy you, but a way in which you can bring your talents, energies, actions, imagination, reason, intuition, and yes, even love to the creation you desire. Love is what creating is all about. And so often when patients come in and they're like, how do I get rid of my depression? How do I get rid of my anxiety? How do I get rid of the voices? How do I get rid of this stuff? A lot of times what I want to balance it with is, let's talk about what we want to need, what we need to bring into your life. What do we need to create? The last piece of this in that flexibility sequence is feedback monitoring. Is it working? Are my interventions working? And I'm just paying attention to the time. I don't want to spend a lot of time on this, but one of the best models we have for understanding outcomes comes from the work of Bruce Wampald and Zach Immel. And the book is The Great Psychotherapy Debate, but it's the contextual or common factors model. And what it really suggests is that the way that we optimize outcomes, and there are two that we care about, and this is specific to treatment psychotherapy, is a better quality of life. So that's creating, what do I want to bring into my life, and symptom reduction. And the three pathways that get us to the very best outcomes in treatment are the healing relationship, expectations, where we really help patients understand, this is to me the learning component, where we help people to understand their symptoms, the nature of the problem, and then what are the solutions that best can help people with those symptoms. And then we actually have the intervention actions. But if you're unfamiliar with this model, it really is fantastic in helping people to understand how to get the best outcomes from treatment. And lastly, George Bonanno himself, he says there is no magic bullet, no single best way to cope for everyone. Every trait, every resource, every behavior has both costs and benefits. What works in one situation for one person may not be effective for another person or even for the same person in another situation or at another point in time. We need to keep adjusting and readjusting as we go. With that, I'm going to stop sharing and
Great.
open it up for questions.
Thank you so much, John. That
Sure.
was a lot of material.
It was. I'm sorry. It was a
It's
lot.
okay. No, it was fascinating, and it's generated, I'm sure, a number of questions by people. And you've just dramatically increased my reading list with all of those books that look like they're quite interesting. I'll start off by asking a question, you mentioned near the end about the importance of self-guided interventions with people who are struggling with their mental health. That's an issue near and dear to my heart, in that I struggle with depression, and I've come up with my own self-guided interventions that I found really helpful. I was wondering if you could elaborate a little bit more on that, or give some examples, or maybe let us know of another book that deals with self-guided interventions. But
you know, I
can. If you could just elaborate a little more on that.
Yeah. I mean, I think that, again, there's a lot of different things out there that fall under sort of the self-help. But part of what I've been after is what are things that consistently I think can help people. So to give you just maybe 2 or 3 different examples, I really love Focusing by Eugene Gedlin. This came out of the 70s. It's a really 6-step process. He's got a book called Focusing. There's a website. You can go to focusing.org. But part of what happens is that we get overwhelmed with everything going on in our life. And what Gedlin discovered in this work is that when you're going through psychotherapy or treatments, people have what he called aha moments, where it's like something walks in, it's like, that's it. And when you have an aha moment, it feels good. And in some ways, that is part of the intervention. So when he was observing people having aha moments in psychotherapy, he wondered, well, can I teach people how to have these aha moments, to take all of this sort of messiness of overwhelm, all these things that I have on my plate, and use this process of focusing to kind of dial in on, well, what is it really that is causing me all of this stirring in my body? And so that's one intervention that I teach patients. People can learn it. There's ways of kind of shortening that 6-step process, but I love Focusing. There are, of course, the obvious things like focusing on sleep, circadian rhythm, focusing on diet, focusing on exercise is an incredible intervention for helping people. In the area of stress and trauma, one of the things that I've utilized with patients is known as trauma releasing exercises. This is the work of David Berceli up in Canada. He's also got a couple books. There's a bunch of videos. But basically, it's the idea that when people have had trauma and he observed them traveling around the world, their bodies would shake. And so part of what he developed was sort of a process of naturally helping people shake, and in some ways recalibrating this nervous system. We don't have tons and tons of randomized clinical trials behind this stuff, but there's a really low bar. There's not a lot of risk of teaching people how to do some of these simple exercises. I've used them myself. And so that's another example of sort of a self-guided tool. Focusing, trauma releasing exercises, yoga, a variety of other tools. Does that answer that, Craig? Yeah.
Yes, it does. You hit on a number of my favorites, by the way, that I've incorporated to deal with my situation. So, audience, if you have any questions for John, feel free to either put them in the chat, or if you'd like to ask them verbally, go down to the bottom of the screen where it says reactions and click on reactions, and you can raise your hand and we will call on you. And let's see. Jackie, is that a question you have there? Let's see. I'm just reading it as we speak.
Yeah, I think I agree with you. I agree, Jackie. I think creating my slides, sometimes I need to go through and edit. But yes, predispositions. Yes, thank you. I can make some edits on my slides.
So I only sent that to the host and the co-host. And so for other people who are wondering what we're talking about, I was just making a comment that the lowest level of the tree graphic, which I think is great. The lowest level though might be more clear if it stated biologic genetic predispositions as opposed to biology and genetics. That's all. It really
it's a great point though. I mean, sometimes I get a little fast in creating my slides. Jan asked, will you explain the 5 actions program, please? Sure. I mean, I'll explain it kind of quickly, but it's basically a program developed to address addiction, and the actions really start with the idea that the starting point is motivation. That was action 1. How do we get people motivated to engage in doing evaluation and treatment and all of that? Action 2 then is, once you're motivated, you do some assessment and evaluation to try to understand what are the different addictions, what is co-occurring, and then out of that evaluation come these 3 buckets that I've called resolve, manage, and create. The resolve bucket is, what is the stuff in my life that I need to go after and resolve? I don't want to manage being homeless or manage being suicidal. I need to resolve these things. But there's a collection of types of issues that are more chronic, that need to be managed. So we need to really appreciate that for some of these symptoms, we need a management type of approach. And then the resolve and the manage is really all about the symptoms and trying to get those to go down. And then the 5th bucket is that create, which is we need to bring things into people's lives. So those in a nutshell are the 5 actions. I'm kind of moving in the direction of simplifying it into what I said today, which is, let's just focus on good, solid screening and assessment tools. Let's then use the outcome of that to educate people about what that means and provide really great evidence-based education. And then from that, really connect people up with interventions. Like, what can you do on your own, as well as connecting with clinicians and accessing treatment.
Great. Thank you for that question, Jan, and thank you for that answer, John. So it looks like we've got about 7 or 8 minutes more for questions, and I see that Claire has her hand up. Claire, take yourself off mute and ask your question, please.
First of all, sorry about my original signing in, and I was creating lots of visual distraction. I'm really focused on intervention as a mother of a son with severe schizophrenia who's been in the hospital now for 7+ months with a real downturn in functioning. And my questions are, when you're working with somebody that is lacking the capacity for reflection with anosognosia, having difficulty with healing relationships, so we're not putting our eggs in the basket of therapy at the moment. What do you think about ECT, and are there other directions you would go in treating people who are suffering in this manner?
Yeah, it's a great question. And, the truth is, I don't have a lot of experience with ECT, so I'm not the best person to try to answer that. I feel for you because, that's a long hospitalization, clearly a lot of challenging symptoms. And so I think in some ways, there's probably not one obvious, easy answer, right? You're looking and talking with a lot of different sort of clinicians to try to understand,
I don't have a lot of resources here.
Right. So that becomes the challenge of, how do I go down this path and what's new? And I think that gets back to my point, which is, one thing we do need to do as a system is make available to you really the very best education, so that you can go and really understand the nature of this problem. What are all of the best evidence-based practices that we have? And in some ways, that doesn't mean that you're going to actually implement those yourselves, but as a mother, part of what you want is to know the territory, and you want to know that as you're going in, how to ask the right questions. That's partly why, I put in that one slide for these emerging treatments, because I suspect that a lot of times as a parent, you might talk to a clinician and they're not going to mention any of this, because part of it, many of the clinicians, they don't even know that these things are coming down the pike, right? But if I'm a parent and I have access to really good information, and I can learn that and do some reading and say, wow, there's a bunch of new stuff coming down here that actually hits the cognitive component of schizophrenia. Wow, that's something new here. We've got these newer agents, then you can have some hope. And that doesn't mean that they're available right away. But again, as we've been talking about within this framework, this is not a sprint, right? This is a longer term marathon that you really want to settle in, and you want to be able to sort of know, okay, how do I navigate this complicated territory ahead of me in the best possible way? So I think that's something that we as a group have to continue to talk about. How do we come up with powerful learning tools so that you can get the answers that you need? It's a straightforward question. You know, what is the role of ECT, and what do I need to know about it? There is a number of presentations I've been to of late, and but it's not my area, so I wouldn't want to comment on it. But it's a good question. So a couple things in the chat just that I'm looking at. Tom asked, would I let people know about my son? He's actually doing really well. He completed treatment right before the pandemic. So, you know, that is good news. He's happy and healthy and doing well. Claire, I think, says, so where do we go for those resources and tools? It's a great question. So if your issue is addiction, then you go to the NM5 Actions program, which is what I created. That's why I have 125 videos and all kinds of content on there that I'm continuing to try to rework. Part of what my work has been of late is building out I've been working with the tribes up in Alaska, and they were kind of the first to come to me to say, you know what, we love what you did for addiction, but what about, you know, relationships and trauma and anxiety and mood and all these other problems? So I've been working on a similar platform that can kind of address all of those other issues. But I think partly when we're looking for resources and tools right now, what I would say is I would use trusted government websites like SAMHSA, National Institute of Health, the resources that NAMI has. I think that you as a group can probably continue to develop resources in a place that again are evidence-based. But one of the things that I've done in the NM5 Actions program, you know, is I've added a lot of resources and links to my videos. And again, there's like 120 videos, but I've been very careful to make sure that most of the time I'm pointing to evidence-based resources that everybody agrees upon. And many of those are, again, funded by our federal government. That's SAMHSA, it's NIH, it's NIAAA for alcohol, it's NIDA for alcohol and drugs. The other place that you can access for resources and tools is, again, the clinicians that, you know, are in your community, treatment clinicians. But I would say that this is what excites me about the opportunity for the digital products, is we have an ability to bring to people a real strong collection of resources and tools that we haven't been able to do, and we're just scratching the surface of being able to do this. I think this is stuff that's coming in the years ahead.
Just to follow up real quickly on what John was sharing with you all, SAMHSA is the Substance Abuse and Mental Health Services Administration under the federal government. So if you put in Substance Abuse and Mental Health Services Administration, you will find their website, and they do have a lot of good information on there, as does the National Institute on Mental Health, which is an arm of the National Institute of Health. They have a lot of good information, and we, NAMI, at the national level have a lot of good, useful information and links and resources on the NAMI Nationals website.
Can I just chime in here and say that we also have, not just for Claire, but for any other people, any other families who are looking for support or education, we have our evidence-based program called Family to Family, and our family support group that meets weekly. So just call us up or send us an email.
Lots of wonderful resources. Yeah, it sounds like, and again, I think you guys are a wonderful resource. I will say that I really think that at the heart of helping people, and, you know, as much as I hit on the digital stuff, it is relationships with people, right? It's face-to-face, it's connections that is the magic. That's what we need to continue to recognize, that we can benefit from these digital tools, but the real healing that comes is through the relationships that we have with each other and stepping in. The tribes have a phrase, they say, holding each other up. We need to do more of that. We need to, again, reach out and connect face-to-face and in these kinds of forums as well.
NAMI's mantra is "You are not alone."
You are not alone. Perfect. Yep. I mean, I will tell you, during my many years with my son, I joined a support group. I talked to, you know, I went to conferences. I connected with other parents. I had to. There was no other way for me to get through all of those years. I had to reach out and develop a community of people that understood sort of what it was like. because we led a different life, so than a lot of parents typically do with kids. So I know that people that have to manage serious mental illness from a similar bucket. You know, we have different experiences, but it's the same kind of a thing.
Yep.
Yes, Jan, you're raising your hand.
I'm very impressed with your approach of cognition on the part of the patient. My daughter is in this quagmire of despair, and I'm looking, and now I know, to go towards addressing with her, encouraging her to be aware of her part in her wellness, as opposed to the psychiatrist or me or the neighbor or what her children or something like that. That's my takeaway from this, and I'm really grateful for it. And if NAMI were to have a program on how we get from, as the parent and the caregiver, from that point of despair to a place of cognition, recognition, acknowledgement that my daughter has hope, that there's a place where she can participate in it, because right now it's all everybody else. Thank you.
Yeah. Thank you, Jen. Fantastic.
Yeah. Any other final questions before we wrap things up? I see a comment from Jackie. John, I liked in particular the information you shared about the distinction between chronic ongoing stress and PTSD. Thank you for your insightful presentation. And with that, I'd like to follow up and say on behalf of the board of NAMI Santa Fe, thanks again, John, for taking the time out to present to us.